Hey guys, nice to see you again. How's it going with you? Is everything okay? Today we'll talk about CT-guided hook wire localization of small lung nodule, session 40. Let's enjoy Dr. Y chest radiology. I'm Dr. Y, chest radiologist, medical professor in South Korea. Let's go. How do you feel about watching these two films? On the left side, young man, healthy, without abnormal findings. On the right-hand side, young woman, healthy, normal, without abnormal findings. For me, these two films are wonderful, very wonderful, great pictures, paintings of the great painter. These are the mother of normal findings. So if we see another film with abnormal findings, we have to compare everything with these two films. Let's go back to our topic. Pre-BATS localization techniques. There are mainly two methods. BATS, video-assisted thoracoscopic surgery. One is injection of material such as methylene blue, microcoil, agar, barium, repiodor, medical glue, etc. And second form is localization of needle or hook wire. Currently, there is no single gold standard for preoperative localization in clinical practice. Every method has its pros and cons, and no single method is perfect. It depends on me and the doctor's skill or experience. Today, CT-guided hook wire localization is relatively widely used. Indications. When do we perform this method? A. Less than 1 centimeter, small nodule. B. Ground glass nodule, suspicious of adenocarcinoma. C. Small, single or two, lung metastasis. D. The nodule is far from lung surface. E. The nodule is not palpable by the surgeon's finger. F. Small surgery, such as wedge resection, not lobectomy, not pneumonectomy. These two axial lung window setting CT shows the two examples of hook wire localization procedure. On your left side, this is left upper lobe of 1 centimeter, small ground glass nodule of adenocarcinoma. And on your right side, this is right upper lobe, 5 millimeter nodule from GI tract malignancy. This is single metastasis. It is known and studied that hook wire localization has some advantages. One is its simplicity. 2. Easy of operation. 3. Short operation time. D. Reduced surgical injury. But regrettably, there are some disadvantages or complications of this hook wire localization method. I don't want to express myself about these disadvantages, but I have to tell you, it's really present. 1. Failure. According to patient or according to the doctors, failure. And second, pneumothorax. C. Hemothorax. D. Local pain. And I don't want to say this one, but it sometimes very, very rarely happens. Death from air embolism. So in conclusion, I can say that the CT-guided hook wire localization is specifically beneficial for the diagnosis and treatment of early small lung cancer such as adenocarcinoma of GGN and a tiny metastasectomy. subscribe, and good is not so important. Your quit smoking is much more important. I have many more clips about the chest radiology, not only about the lung cancer, but also chest anatomy, pneumonia, pleural effusion, non-tuberculous mycobacterium, sarcoidosis, etc. in this channel. Please enjoy more. And if you want to learn Korean or Japanese languages, I have two for you. You quit smoking this year? What a happy message for all of us. You'll be healthy, wealthy, and happy without smoking. Structure of Copan's style hook wire. This is the assembly of the needles. It is composed of two parts. One is this one, from here to here. This one is introducer. It is actually longer form of syringe needle, beveled edge with tunnel, empty tunnel. And second one is this linear, thin, long needle shaped hook wire. This is hook wire. And if you see closely this one, this is the needle introducer, and in the inner one is the hook wire, Copan's hook wire needle. This length is 1 centimeter. He is Dr. Daniel Coppens. He is the founder of breast radiology in America and all of the world. He works in Massachusetts Hospital, General Hospital in Boston. Now I tell you how I do my work with these needles. This is introducer, and inside this needle there is a hook wire. I introduce this needle tip, introducer tip, as near to small tiny nodule of my target, not exactly to the target, not possible, not necessary, just around the nodule, near the nodule, and then slightly push the hook wire a little more. And then I retrieve the introducer and let the hook wire needle remain just around the nodule. That's it. That's all. And then the surgeon will find out the nodule following the hook wire needle. These two CAT scan images will tell you what happens during the procedure. On your left side, this is a tiny metastatic nodule from GI tract on her right upper posterior segment. 5 mm nodule is here. From anterior approach on supine position, the distance is too far to accomplish. And there are so many pulmonary vessels. These vessels are looking so dangerous to me. So I decided to go from backside, short distance without pulmonary vessels, less pulmonary vessels. So the patient is in prone position from backside. I introduced the hook wire needle here, this hook wire needle. Yes, it is not exactly to the target nodule, just around the target nodule. So I can tell the surgeon where is the nodule with relationship with the needle tip. And the surgeon took out the nodule after surgery. Now the session is over. How do you feel now? Satisfied with the procedure? Yes, thank you for watching me. Be healthy anytime, and please just don't smoke. Thank you very much.